So before, real quick, Robbie Bolton asked if I would mention that he's having a speaker come in who's having a book signing. The book is Geek Heresy, and it's a lot of IT stuff and integrating with healthcare. And he's from U of M. He's going to be here next week. So just wanted me to give a shout out for this for you all. So who knows? There may be more extra credit in for that. I don't know. I'm not speaking for your professors. I'm just speaking, maybe suggesting that may be a good thing, right? Because extra credit's good, right? Yes. All right. That's why you're here, right? Honestly, right? No, none of you woke up and go, I want to go hear Ray speak. All right? You went, I want to go get extra credit. Okay, Dr. Baldwin, thank you. Thank you. Being honest, Dr. Baldwin was not far from the truth. My previous role prior to being in nursing, I was an actor. I was able to, that's funny. That was not meant to be funny. Thank you. Thanks for laughing at that. No, I did play a role with Tom Cruise. Any of you heard Tom Cruise? In one of his earlier movies, it was All the Right Moves, and it was actually filmed at my high school. And so we got to spend 6 months with Tom Cruise, Craig Thompson, and Leah Thompson, Craig T. Nelson. And it was a pretty awesome experience. It actually paid for my way through school. And so we can talk more about that later, but that was a pretty exciting way for me to start off my life. And then I realized, okay, Tom Cruise was getting a little weird, and just wasn't one to hang out as much with me anymore, and he was jumping on couches and acting crazy. And so I was like, okay, I need to find another job. So I said, I'm going to go to nursing, and made the choice to switch to nursing. And it is something that I have never regretted. I have loved being a nurse, and it has given me an opportunity to be a minister without a title. All right? Because when you have the opportunity to be at people's bedsides, and they are passing from this world to the next, and the last breath they take and the last look that they look and they see you, knowing the next face they're going to see is Jesus, that's pretty humbling and pretty awe-inspiring. So I'm really enjoying my role as a nurse. So I want to talk to you a little bit about nursing. I had a student come, a prospective student, last year when we were launching this program, and the student in all sincerity said, Mr. Jones, I don't understand why we have to take science to be a nurse. Yeah. And after I picked my jaw up off the floor and let the reality of what she really said sink in, thinking, okay, you're never going to make it in my program. No, I didn't say that. But I said, what do you mean science has nothing to do with nursing? And she said, we learn all this stuff. We learn all these facts, and we learn all of these figures, and we learn body parts that, okay, it's a body part, I might need that, but, lab values and chemistry, and why would I ever need that? And I was dumbfounded. Because science and all the research shows that the better you do in science, the more successful you're going to be as a nursing student, but also the more successful you're going to be to pass the NCLEX, which is the benchmark for all of the nursing students who are in this room today. All right, when you graduate and walk across the stage and President Ellis hands you this nice diploma and says, congratulations, a lot of you in this room can right away start in your job and in your position. The nurses have to wait to pass the national licensure exam. And until they do that, they cannot be employed. So that is their benchmark. So what does science have to do with nursing? One of the big things that science has had an impact in nursing is beginning to set some benchmarks to improve the quality of healthcare. All right? They've done a lot of research around some of these areas in looking at STEMIs or non-STEMIs. All right? Now, a STEMI stands for ST Elevation MI. basically that's somebody that's having a heart attack, okay? There can also, when you look at it, when I look at an EKG and I look at the PQRST waves and I see where they are, and if I see kind of like a fire hat look on it, I can tell that person is having an active MI and they need to get to the cath lab, all right? Well, there's some benchmarks that the Joint Commission, which is the governing body of all the hospitals, they've said that we need you to do certain things in a certain time frame to improve the outcome. So number one is door to EKG. Within 10 minutes, you have to have an EKG and it has to be definitive, and the physician has to read that and determine, do they have a STEMI or do they have an NSTEMI, and do they need to get to the cath lab? Because the earlier they get to the cath lab, the earlier they can insert a balloon in, they can open up those vessels, and that heart is going to get oxygen, the blood's going to flow better, there's not going to be any occlusions, they're going to have a better outcome and they're going to live, and that's what we want for our patients, isn't it? Thank you.
Please.
Thank you. All right, stroke protocols. Been a lot of research about stroke. So now when the EMS calls in and says, I have a patient with a confirmed stroke, we instead, when we greet them at the door of the ER, we take them straight to the CAT scanner where we get a CT image, and we have to have a radiologist approve and read that image within 40 minutes to determine what our next steps are. Do they need a coil? Do they need TPA? If they're within a 3-hour window to get TPA to begin to reverse some of the loss, a patient who's had a stroke, the effects of losing a left side or right side, getting TPA early for them. The research has shown that the sooner they get that on board and the sooner they get that done, it's going to have a much better impact on reversing. They could try it maybe as outward as 5 to 6 hours, but it's going to have less impact, all right? So this is how science impacts what we do. CPR. When I first began as a nurse, I learned CPR, and I learned this acronym, and it was ABC. Airway, breathing, circulation, all right? And that's how we did CPR for many, many years. But back in 2013, the American Heart Association did a lot of research, and they found that it wasn't the airway that improved a patient's outcome. It was two other things. They quickly got a defibrillation from an AED or defibrillator, or somebody quickly jumped on the chest and began doing compressions without the airway or without the breathing. Getting that blood flow and that heart pumping again provided a better outcome until a definitive care team arrived, like the paramedics, and they could begin to provide care and the better outcome for that patient. The other thing that they found out in the research was, as they interviewed people, they were very intimidated about that mouth-to-mouth resuscitation piece. That was intimidating for people, especially if you're at Walmart and somebody goes down on the floor and you don't know them. How many of you want to put your lips on theirs? You could. I mean, a lot of people were carrying around those mouthpieces, so there could be a little barrier, people who really did want to, but most people are going, good luck with that. But now that they've changed this and people are going, okay, I don't mind doing the chest compressions. I can get that going till the paramedics arrive. There's been much better outcomes with that based on the research. All right. Can we dim the lights here? Can somebody? I want to show you a video. After I began practicing, I was an ER nurse and a flight nurse for many years. And as I began to take more positions in leadership, this became a passion of mine. And I had the opportunity, and some of what I'm going to share to you, I want to give credit to Dr. Brian Sexton, who is from Duke University. Brian and I are friends, even though he's from Duke and I'm from UK. And those of you who are basketball fans will understand that. Brian began to do some research many years ago on the science of safety, and then began to notice some correlations between the airline industry and the health industry. And so I want to talk with you about that, because I know we've got nurses, potential nurses here. I know there's potential of you who may want to go into other forms of healthcare. And it doesn't matter what your title is in healthcare. What really is important is that you understand errors can happen in any aspect of that healthcare environment. And whatever we do, we need to keep our patients safe. So some of the issues that I want us to talk about is estimates are that 44,000 to 98,000 people die annually in hospitals due to errors or mistakes. And that's from the Institute of Medicine. That was a research piece that they did back in 2000. And after all of these years, those numbers have moved just slightly, all right, for the better. But they're still in that big range. What's happening? You've got medication errors. There's adverse drug events, needle sticks to staff. Wrong orders were put in by the physician on the wrong patient because the patients had two very similar names. They were spelled the same, they had the same initials, and people did not use two patient identifiers to identify that patient correctly. Look-alike, sound-alike medications, all right? What if the doctor says, I want you to give your patient insulin? What are you going to say? Which one? NPH, 70/30. There's lots of kinds of insulin. So you don't just use these generic, you don't use generic abbreviations too. In healthcare now, you are not allowed to abbreviate. Everything has to be written out because of safety issues like this. Hospital-acquired infections and hospital readmissions, all right? There's been a big CAUTI study here in Michigan done with a lot of our hospitals on the value of putting in a Foley catheter. When I began in nursing and we had a drunk patient came in and we knew they were going to be there for 12 to 15 hours, I would put a Foley in them and not worry about them. If they needed to use the bathroom, they could just automatically go. But as the scientists started looking at that data and realized those patients were getting acquired infections because of the length of time those Foley catheters were in the patients. And not only were they getting hospital-acquired infections, but that infection would continue on, and then they would get sicker when they went home. And then they would come back within 30 days to be readmitted to the hospital, all right? So we really weren't helping our patients. We had to find a better way. We had to find a safer way to do things and take care of our patients' needs. Wrong site surgeries. Patient goes in expecting to have their right leg amputated, come out with their left leg amputated. Yeah, that's big. Because guess what? What are they still losing? The other leg. That's dramatically changed their life. Now when you go into pre-op, it's your responsibility as a patient to identify that site of where you're going to have surgery, or if something needs to be removed, you're the one that's identifying it, so it helps to ensure the right thing is being done. Patient falls, delays in diagnosis. This, I remember in the ER, if there was if there was an equipment malfunction, we could do point-of-care tests with patients that we suspected were having a cardiac arrest or an MI, and we needed to do bedside labs like a troponin to see if they were actively having that heart attack. If that machine didn't work right and it kind of prolonged that diagnosis, then that impacted that patient's potential recovery time. Outdated equipment, a failure to act. I know of a situation where somebody said to their nurse, I have abdominal pain. And the nurse ignored them, thought they were just complaining. Actually said to them, you're in your room eating, drinking root beer and eating chips. Seriously? you're having abdominal pain. They had an internal bleed and ended up dying. This is all at a cost of $17 to $29 billion annually. All because people did not double check or pay attention or listen. James Reason, who wrote the book Human Error, says, rather than being the main instigators of an accident, frontline workers, which would be anybody in healthcare, nurses, techs, physicians, anything like that, tend to be the inheritors of system defects. All right? That's an important term for you to understand. What we're saying is, this is not you who is a screw-up. Nobody wakes up in the morning and goes, I want to harm a patient. If you do, you're not graduating from my nursing program, okay? Nobody wakes up and goes, I want to be a screw-up fairy today. We come with our best intentions to provide the best care we can to our patients. But there's system defects. There's things in the bigger system that we work within that create some difficulties for us to do our jobs, and that's what we're identifying. Their part is of adding that final garnish, that last thing. You giving that medication, that's not what messed up the situation. There were pieces behind that, and I'll show you in a minute what I mean. There were pieces behind that that caused that screw up. Their part is of adding the final garnish to a lethal brew that has been long in the cooking. So here's what I mean. This Swiss cheese model, all right? Anybody like Swiss cheese? It's good. All right. Here's what happens, all right? And I don't know if this has a pointer. It doesn't. Oh, yeah, it does. There we go. So, right here, patient comes into the ER. The nurse or whoever is intaking that patient doesn't document their allergy, okay? Ding number one. That patient moves along, sees the physician, and the prescriber writes an order for the medication that the patient is allergic to, all right? Ding number two. Step number three, the pharmacist, where the medication is going to come from, fails to check the allergy status, which if they check the allergy status, would they be able to identify that? No, because it wasn't identified, right? Ding number three. Finally, the nurse in the ER gives the patient the drug which they're allergic to, and the patient dies. Now, the reason this is the Swiss cheese model, if you look at Swiss cheese, all those holes aren't, I mean, it's not like somebody takes a drill and drills equal, even holes in a chunk of Swiss cheese, right? What happens here is this just happens to automatically line up. And the accidents happen because people didn't pay attention to the little details that they needed to. This is one of the most stressful work environments on the planet. This is a cockpit. It's what a 757 looks like on the inside. The research that Dr. Sexton has done in relation to airline safety has discovered that 70% of airline accidents involve human error. If you go back to any of the post-investigations of any of the airline crashes, you're going to see this acronym, CFIT. Stands for Controlled Flight into the Terrain. All right? Now, other than the terrorists on 9/11 that intentionally took over our cockpits and drove our citizens into the Twin Towers and into the field in Shanksville, Pennsylvania, and into the Pentagon. Pilots do not intentionally fly those planes into the ground. when you think about the stressful environment that they're working in, hearing the different people talking to them, getting the different orders, getting the different directions, looking at that very complex data field in front of them, trying to discern what those readouts are saying and what it's telling them, and you're flying 700 miles an hour. An accident, making a right turn instead of a left turn or left bank, is going to put you into terrain. If you're flying in fog, you can get disoriented and you're going to go into the terrain. So, what does that mean for us? We work in a stressful environment in healthcare. So, usually, because many are short-staffed, there can be limited training. Our staff get lack of sleep. I used to work 12-hour shifts. Many times I would work longer because in the ER we were boarding patients, and we had patients everywhere. They were sitting in chairs, they were sitting in hall beds. I'd have 4 to 6 rooms that I was assigned to. It was very stressful. I'd come home late, not eat well. Staffing is limited. You'd have people who called off because they got sick, because they're in an environment where they're dealing with sick people. There's a lot of production pressure. I mean, think about it. You're taking care of a life, right? That's pretty important. Distractions, call buttons going off, people asking for stuff. The minute you come out of one room, another patient or their family's coming up to you saying, I need this, I need this, I want this, I want this. Lots of distractions. Hearing babies cry, right? The toughest thing I ever had to do was start an IV on a baby who was kicking and screaming and shrieking. I mean, trying to stay focused in that moment and not deal with that distraction, that's a lot of pressure. That's a lot of stress. Our patients are much sicker, all right? Now, since the ACA has been put into place, we have more people that do have health care, but it's overwhelming our care centers, our ERs, right? But the other side of it is they're not just coming in because they're paying more out of pocket, so they wait until they get sicker, and when they come in, it's not just a simple, oh, let me give you an antibiotic. It's a major course workup and a major treatment plan. The other thing that's hard is our health literacy challenges. The latest research in health literacy is that 1 person out of 4 can read the headline of a newspaper. That's sad. Now think about this. How many of you have been in the hospital or in the ER? When they discharge you, when they're done and they're finishing their course of treatment with you, they give you a packet called a discharge instructions packet. That is a minimum of probably 14 pages of everything that happened to you today, all of your reports, all of the directions of what you need to do to take care of yourself, and how the medications you were given, the medications you're going to get from the pharmacy, how you need to take them, what you need to take them with food, without, what time of the day do you need to take these medications, a lot of that. Now, if I just handed you and said, here's your discharge instructions, have a good day, see ya. How's that going to help you? If you're one out of the 4 that can't read the headline of a newspaper, and you're going to read all those medical terms, not even drug names, it's overwhelming, isn't it? It's stressful. So here's our challenge. We work within a healthcare system that relies on perfect performance every time. You do not have a day in a healthcare environment where you can screw up, where you can make a mistake. We work within a system that was designed to provide a punitive approach when errors have occurred. What does that mean? We're stressed. just like you around midterms, or taking some of those science exams. You're praying for Jesus to come right now. Here's the thing about stress. Stress comes from two sources. You can do this with anything. It comes from things you cannot predict. You walk into science class and your instructor says, "Pop quiz," and smiles. Are you smiling? You're praying for Jesus to come again. Things you cannot predict, and then things you cannot control. How many of you have control over the questions on the exam? Oh, wait a minute, there may be 3 hands in here. The professors do, but you don't. So what does that do? It causes stress. So Dr. Robert Sapolsky has done a lot of research in baboons and in Africa, and he's looked at the stress. Now, earlier I said to you, it's really important that you understand the difference, that you understand the relationship with science and how it impacts healthcare or nursing, whatever. When you study those science classes, you cannot think of them in isolation. If you're taking anatomy and physiology, you cannot look at it and say, okay, well, I learned the parts of the leg and feel good about that. If you're studying a chemistry course and you learn the periodic table, good. But you can't feel good about that. How many of you ever have heard the name Bloom's taxonomy? Bloom went to Michigan State. Go green. Right here. All right? He came up with this list of learning. It's kind of phrases and learning objectives that goes from the lowest level of learning to the highest level of learning. And that lowest level is knowledge. It's things like facts and figures. The highest level of learning, he says, is evaluation. So when I say to you, it's important for you to understand the relationship of how science impacts whatever field you're going into. You can't just spend your time at that lower level learning, because that's not going to be helpful for you. You have to put yourself into an environment where you take that baseline knowledge and that baseline facts and that baseline information and you integrate it. You use evaluation skills to say, okay, what does that mean? I know an EKG that has an ST elevation means a heart attack. Now, what do I do about that? This is the same thing with stress, all right? Dr. Sapolsky did a lot of research, and what he found, there's two kinds of, when hormones are released in us, when you're scared, when somebody's chasing you, when you have a tiger that's, a cougar that's chasing you out here on the sports field, you're running for your life, right? And you've got that adrenaline and glucocorticosteroids that are kicking in to kind of give you that extra boost of energy. That energy is going to your thighs, that energy is going to your mind to think, all right? Everywhere else it's clamping down. Okay? That's great, and that works really well in those short bursts. So you can get away from that danger, you can get away from whatever that issue is that may be life-threatening. Here's the problem. When we endure stress, those same hormones are exhibited, and they're launched in your body. And if you're spending all of this time worrying and stressing about pleasing a roommate or pleasing a professor or whatever other emotional, psychological issue is causing you stress, those same hormones are going to still be fired, and it's going to be at a longer period of time. What does that mean for you? Here comes the evaluation. You're going to get diabetes. You're going to have problems with your blood pressure. You're going to have heart trouble. Dr. Sapolsky says stress can wreak havoc with your metabolism, raise your blood pressure, burst your white blood cells, make you flatulent, ruin your sex life, and if that's not enough, probably even damage your brain. Stress, if not managed appropriately or dealt with appropriately, can cause significant damage. So, I want to do a little poll. How many of you have skipped a meal this past week? Raise your hand. Okay. How many of you ate a poorly balanced meal? Okay. How many of you went an entire day without a break? How many of you changed your personal or family or work or school plans because there was something you needed to do for a sport or a project at school? How many of you changed those personal plans? How many of you consistently arrive home late from work or school? How many of you drink too much coffee? Now, I don't think you can drink too much coffee, right? So I would object to that question. How many of you are sleeping less than 5 hours a night? All right. Can you feel the stress level in this room? Here's what the research shows. 80% of Americans get home from work late. Late is after 8 o'clock. All right? I'm not talking 5:30, 6 o'clock, 8 o'clock in the evening. 15% of Americans get to work late. Why? They didn't get enough sleep. 40% of Americans regularly sleep less than 5 hours a night. As a result, we're 2 times more likely to die of heart disease and 1.7 times more likely to die of all causes. The interesting thing, and this is why I raised the issue of the coffee, the research was done by a man by the name of Cappuccino. Just saying, you can't have enough coffee. Here's the impact. Half of our hospital staff have been emotionally exhausted. You as students are emotionally exhausted. 2 out of 3 staff have difficulty sleeping. 1 out of 4 staff are clinically depressed, and we wonder why we're not able to perform better. So I don't know if you've seen this. Despair.com. I love those motivational posters they have on there. This one says, tradition. Just because you've always done it that way does not mean it's not incredibly stupid. All right? And there's a lot of truth to that. So the traditional approach to error, and when you make a mistake because you've been under so much stress, is that it gets explained away. All right? And the word for that is we put the blame on somebody else. It was my boss's fault. It was the patient's fault. It was the doctor's fault. It's the professor's fault. It was my roommate's fault. I mean, we just play this blame game. The second thing is problems are eliminated at their source, all right? And I call this the Donald Trump principle. You're fired, all right? No, that's not a political endorsement, okay? No, that's not where I was going. But instead of, remember what I said at the beginning? These are system errors. These are not individual personal errors. This is not you waking up going, I want to screw up. They're system errors. And the problem is people have been fired and eliminated because they were that garnish. They were that last piece, that last cut of cheese that let the error through. And they just totally deny and disregard everything that happened prior. So as a result, our joy in our work is diminished. We waste resources. Needless harm is caused, our resilience is dripping away, and we're most vulnerable to burnout. So we have to relook at focusing our attention on a system approach rather than an individual approach. We have to evaluate, how do we take care of our patients? How do we take care of each other? Faculty to faculty, students to students, and finally, how do we take care of ourselves? Dr. Sexton has said, if we do not take care of ourselves, we will not adequately take care of our patients. So I want to do two things as we close. The organization that I worked for in Grand Rapids, we developed this tool. It's called Learning from Defects. And as a way to begin to work with our staff and empower them to identify defects within the system and not play the blame game, we utilized this tool and allowed them to identify things that came up when we weren't there as leadership, or things even if we were there that we didn't see, and allowed them and empowered them to call that out and say, we need to do something about this. I think this even has opportunity on a campus environment too, where there's issues or concerns from faculty or students to be able to raise a flag and say, let's just look into this. Let's not blame somebody. Let's not put this fault on somebody, but let's just talk about this. Let's work this through. The other thing is 3 good things, and I'm going to pass this out to you. Could you guys pass this out real quick up and down the aisles? So I'm giving you a tool that I would like you to use for the next 14 days. You don't have to do this. This is not part of your extra credit piece. But this was a tool that we've utilized in our system to help people who are struggling with stress. Basically, what the tool does, it's not very hard. It's not complicated. But here's the reality. The last thing that is on your mind when you go to bed at night is going to stay on your mind throughout the night. Now, the last thing you're thinking about is a project that you can't seem to work out for a class that's due tomorrow, you're not going to get good rest. You're not going to get good sleep. But if the last thing on your mind is you got to spend some quality time with a friend that you've developed here at Spring Arbor, you're going to sleep pretty well. So what this exercise offers you an opportunity to do is, for 14 days, as you get into bed, it asks you to think about 3 good things that happened to you this day. Now, it doesn't need to be complex. It doesn't need to be super spiritual. It could be, I got to go to the bathroom today. And as a nurse, that's huge. Again, not a Donald Trump reference. All right? But simple things. Had a good meal. Got to go to Frosty Boy with some friends and get ice cream. Or had a good talk with a friend and just was able to vent. Those things. So kind of name some of those good things that happened, and then try to call out the one that was most meaningful to you. All right? And as you go to bed, think about those 3 things. And here's my challenge for you. At the 15th day, if you do this for 14 nights, on the 15th day, I want you to just kind of reflect back to where you are today and reevaluate your stress level. You may even want to, after today, you may even want to write down a little journal note about where your life is today and the things that are stressing you out, and see what changes in your life as you implement these 3 good things, all right? Any questions for me? Yes? What was most rewarding to me as a nurse? I had a trauma patient that was head-on to a deer, and the deer impaled itself into the front windshield of the car. And the woman was brought in, and she was in really bad condition, had some internal bleeding, and she was a Christian woman. And the social workers that worked with us had already put out a page. She wanted her pastor and her husband to come in. And as we were trying to allow for that, but as the time moved on, she decompensated. Her blood pressure started going down, could tell more bleeding was happening, and I realized we needed to get her to surgery rather quickly. And I walked in the room and I said, Mary, I said, I know you want to wait for your husband and your pastor to get here to pray with you. But I said, if we don't get you to surgery, I'm not sure you're going to be here to pray with them. And I said, you know, I also have been a pastor. And I said, you know, I work for a Catholic hospital system. And I said, I would be happy to pray with you if that would be all right with you. And then we need to get you to surgery. And she said, I would really appreciate that. And so I unhooked her from everything on the monitors. We got her packaged up with my tech. We began to wheel her. And when we got into the elevator to get up to the surgical unit, I just held her hand and knelt by her bed and prayed. She lived. And the note that she sent me, probably one of the most special notes that I've ever had of anybody saying thank you for taking care of them. You don't realize the impact if you just really have a heart to care and you really put yourself in that environment to care for those patients. God can use you as a miraculous tool to change people's lives, to transform people's lives, to give people hope, to give them new life. I mean, I can't tell you the countless times that we've worked on a patient who's come in, who's not breathing, whose heart is not beating, and I've worked on them for 45 minutes and they've lived. I say, go God. Well, so typically they say after 6 to 8 minutes, you're going to start having brain damage, especially without oxygen supply. So that's where we're going to intubate you, start breathing for you. But even at that, there may be more permanent damage. Any other questions? Thank you so much for being here today. Have a great day.